Thank you very much for the kind invitation. It is a privilege to participate in this year's Vascular Symposium. These are my disclosures. So why should we care as vascular surgeons about aortic arch pathology or its branches? More often, our aortic pathologies involve ascending aorta and aortic arch, much more common than the descending thoracic aortas. And as you know, aortic dissections are more frequently encountered involving ascending aorta. Especially in type A dissections, even after type A dissections are repaired with open surgery, typically residual dissections degenerate into aneurysm without treatment across the aortic arch and thoracoabdominal aortic segment. So far, we will be talking about fenestrated branch TEVAR devices, but other options like parallel grafting, hybrid repair, and open repair should be offered to these patients. Hybrid repair can be a good option depending on the seal zones. For zone 2, left subclavian artery can be transposed onto the carotid artery, or a short bypass can be performed from the carotid to subclavian artery. For zone 1, TEVAR can be accommodated by having a carotid subclavian artery bypass. For zone 0, usually median sternotomy is required. Then the innominate can be bypassed to from an ascending aorta with side biting clamp on the ascending aorta. Alternatively, the entire ascending and the arch can be reconstructed and frozen elephant trunk can be placed into the descending thoracic aorta, setting up for the future. At high volume centers, these can have excellent results, but still carry risks. Parallel grafting is where you run the branch component alongside of the aortic components, and you can run your branch component in an antegrade fashion, like snorkel or chimney configuration as you've seen here. And you can do multiple branches at the same time, or you can run your branch retrograde and resulting in a periscope fashion as you see here. This is not a technically challenging procedure to do as far as the catheter and wire skills. This recent series of 27 patients having good outcomes, despite 1/3 of them being emergent cases. Stroke rate was 11%. About 1/3 of these patients required reintervention. At USC, we have gone away from triple and multiple parallel grafting in the aortic arch, but one configuration that we found to be very useful still, especially in type aortic dissections, is called Periscope sandwich technique, which I'll show you how to do. This is very simple to do. As the name suggests, we run the branch stent in periscope or downgoing fashion that you see here, and it is sandwiched between the aortic pieces. Typically, we use this for the left subclavian artery. So the steps are: we first deploy the aortic stent graft distal to the subclavian artery origin, and typically through a brachial artery cut down on the left side, we introduce the branch stent in periscope fashion, which is then sandwiched with another proximal aortic stent graft within the first one, landing just distal to the carotid artery. And this is the configuration that we want to achieve: the gentle compression and then without kinking, minimizing the gutter space. This is a typical case here. You see the type A aortic dissection successfully repaired with a subclavian artery incorporation using periscope sandwich technique. And you can appreciate a gentle spiral downgoing branch that is created that ends in the middle of the first descending thoracic stent graft. This is helpful because it sets up for the future. Compared to alternatives like branch grafts or in situ fenestrations that I'll be going over, it sets up for the future. If the patient needs a future proximal extension with branch fenestrated arch graft, now you have the proximal seal zone all the way down to the inlet of the sandwich periscope bridging stent. So you can put in a dual branch into the ascending aorta in the future. If the patient needs a distal extension, you can simply do that with a TEVAR piece by using the distal seal zone that is preserved. And if the patient needs a fenestrated branch work for the thoracoabdominal segment, now you have preserved the left brachial or upper extremity access pathway to the target vessels. So this is an example of one of my patients that we had extend to thoracoabdominal aortic aneurysm, but the proximal seal zone actually required coverage of the subclavian artery. So it's decided to do this in a staged fashion, starting with a sandwich periscope configuration first, which is done here. And you can see it was successfully deployed here, and the sandwich periscope branch ends here, leaving all this area for future overlap. Second stage was performed with a physician-modified 5-vessel fenestrated branch EVAR because the patient had 2 renal arteries. And this is our modified piece that you see here. And the end result that you're seeing here, all the branches are incorporated using left brachial approach, leveraging the sandwich periscope branch that was already placed as a first during the first stage operation. So our results, we published our 20 consecutive initial experience. Now our numbers are double of that now, but you know, the results are seen here, and we experienced no arm ischemia, no branch stent occlusion during the follow-up, but one patient did have aortic rupture in between the 2 planned stages. Now, before moving on to the true fenestrated branch TEVAR, there are special considerations in the arch. The hemodynamic forces are much more severe, and because of this arch hostile hemodynamics and also very angulated anatomy, stroke risk is possible, and there's severe vector misalignment. Typically, what you do at the groin by manipulating the stent graft, particularly in radial orientation, does not translate to the movement across the aortic arch. For this reason, fenestrated TEVAR is a very challenging procedure to do, and it has not made it across the entire aortic arch. Typically, the configuration that Cook fenestrated stent graft has is a large scallop for the innominate and or carotid artery, and a single fenestration that is designed to align with the subclavian artery. The results are seen here, but 20% 30-day mortality illustrates how sick these patients were at the time of enrollment. More forgiving is a larger open fenestration seen in the Judah graft here, where these fenestrations are much more forgiving rotationally, and they simply have to be aligned longitudinally. This is ideal for pathology in the inner curve of the aortic arch. Single branch TEVAR pieces here at the scene Mona Lisa is specifically designed for left subclavian artery. Feasibility trial has halted several years ago, and there have not been any updates. So it is uncertain whether this device will actually see commercial use. The closest device to the commercial availability is GORE TBE, or single side branch device. That is a single retrograde inner branch device, which is off the shelf. And it can be used for innominate, carotid, and subclavian artery with or without adjunctive cervical debranching that you see here. We have done these cases at USC. This is one of our cases. Typically, we establish left brachial to femoral through and through wire access, which can be fed through the preloaded wire system across the inner branch. The aortic piece is deployed first, then over this through and through wire, a branch component is introduced from the femoral approach. And as you can see here, sheath is advanced here, and it is crucial to modulate the tension here as the branch portal makes a fairly sharp right angle. Then we do a selective angiography to mark out the vertebral origin. Then the branch component is delivered and deployed. Feasibility study showed perfect results in zone 2 patients. Pivotal trial is moving very fast, has already completed zone 2 enrollment. Now, multi-branch endograft is much more complex. What not to do is this unibody design where the branches are actually pulled into the target vessels through a very complex maneuvers, as evidenced by 16% stroke rate in these patient cohort. And when triple branches are used, 42% stroke risk reflects complexity of this operation and this device. Cook inner branch TEVAR was pioneered by Dr. Cherry Abraham that is designed to be implanted with a single pass. It has self-aligning features, and no rotational manipulation is performed. However, at this time, this device remains investigational at select PSID centers. Bolton relay branch device is very similar to Cook inner branch device, but it is currently in feasibility trial. We're one of the sites, and this is an example case here. This patient had distal aortic arch pathology, aneurysm, with adequate access here. And you can appreciate this, that the pathology extends all the way up to the subclavian artery. Again, this device has two sheaths. One outer sheath is parked actually at the descending thoracic aorta to give you pushability, and the inner sheath is advanced, still constraining the device. At this point, the wire is in the left ventricle. And there's also a pacing catheter introduced from the femoral artery. The nose cone is advanced across the aortic valve. And once it is positioned, arch angiogram is performed, finalizing the location of the supraaortic branches. And under rapid ventricular pacing, this device is deployed with the final deployment of the proximal clasp. Then sequentially, the innominate and the carotid artery is cannulated to the inner branches that are located next to each other. You always want to confirm branch cannulation. And you measure out the length, and you advance the dedicated branch stent into each portal one at a time. At this time, the right carotid artery is clamped through an open cut down. And you can appreciate the rapid ventricular pacing here, again, for the branch component deployment. And same thing is repeated from the left carotid artery, while the right carotid artery was completely repaired and restored flow. Completion angiography shows successful exclusion of the lesion. Left subclavian artery is bypassed to, and you can see the plug there, and dual branches are seen here. Of course, if you don't have access to these devices, you can do custom modification for the aortic arch. This is much harder to do, and the main concern is the impact of modification process on the stroke risk. This is one of my patients who had inner curved distal aortic arch aneurysm in conjunction with a very large descending thoracoabdominal aortic aneurysm. Again, confirming the location of this here. So we decided to imitate the Najuta graft for the innominate and the carotid, and a retrograde branch for the aberrant right subclavian artery. Again, this is our preloaded system. And you can see here in the video that the main graft is simply just deployed with longitudinal alignment. Now we're working on snaring and bringing the through and through access for the retrograde outer branch for the aberrant right subclavian artery. The final branch component is the self-expanding viabond introduced from the femoral approach, similar to the TBE device. Completion angiography shown here, and successful result. Now, this was performed in 2018, and patient has been doing well now for 3 years. In situ fenestration is another option. You can use needle, back end of a wire, energy source, typically 2.3 millimeter spectranetics laser probe is what we use in conjunction with tour guide, steerable sheath, and this is fairly easy to do in emergent settings. So in summary, parallel grafting and in situ fenestrated TEVAR can be used in emergent settings. Fenestrated branch TEVAR is rapidly evolving technology, and off-the-shelf branch TEVAR device probably is what is going to make it to the market availability in the near future. Future research area, cerebral protection technique and devices, dedicated devices for this technology is really still in its infancy state. Really, I think we need a way to better anticipate the device rotation and the interaction between the device and the aortic arch and hostile anatomy. And also more wide application of custom devices with self-orienting feature, I believe, is the key to safer, technically easier procedures across the aortic arch. Thank you very much.